Society often models human sexual health on macroscopic, binary assumptions. We tend to view our anatomy through the lens of cultural intuition, rather than the actual physics and virology operating beneath the surface. To correct this, we are going to deconstruct 5 widely held clinical myths. We will examine the body as a mechanical system, applying the principles of material physics, anatomical morphology, and statistical data. This requires a strictly academic approach. We will rely on precise medical terminology to maintain rigorous clinical accuracy throughout this module. Evaluating sexual health through a mechanical and statistical lens is the most reliable way to predict and ultimately prevent biological system failures. The first misconception we need to address is the assumption that layering 2 latex condoms linearly compounds barrier effectiveness. The material physics of a dual latex environment dictate the exact opposite outcome. When you place 2 layers of latex in direct contact, the coefficient of friction between those surfaces increases dramatically. This diagram shows a cross-section of 2 latex layers. Kinetic movement generates immense shear stress. Opposing forces catch and pull, causing rapid physical degradation. Microtears form along stress vectors, escalating into a full macro rupture. Once the outer layer's structural integrity fails, a domino effect takes place. The inner layer is instantly subjected to erratic, concentrated stress at the exact site of the tear, causing it to fail simultaneously. Adding protective material without mathematically accounting for the resulting kinetic friction practically guarantees the total mechanical failure of the prophylactic. A second pervasive misconception revolves around hymenal morphology, specifically the belief that the hymen is a complete sealed membrane that is physically broken during intercourse. The clinical reality is quite different. The hymen is a mucosal tissue ring encircling the vaginal opening, and it features significant baseline elasticity. This diagram illustrates the standard annular morphology, naturally containing superficial notches and fleshy tags. Common variations include the fimbriated type, characterized by fringed edges, and the crescentic variation, notable for a natural tissue deficiency between 11 and 1 o'clock. In forensic gynecology, understanding these natural anatomical clefts and variations is a strict protocol. They must not be misdiagnosed as indicators of physical trauma or previous sexual history. Contrast these healthy, standard morphologies with an imperforate hymen. A true total seal is actually a rare medical condition that blocks menstruation and requires surgical intervention. High morphological variance is the baseline rule of human anatomy. Applying a binary assumption of intact versus broken to this tissue is medically invalid. Moving to virological mechanics, our third misconception is the assumption that all sexually transmitted infections strictly require fluid exchange or full penetration to transmit. Pathogens operate under different mechanical rules. Fluid-borne viruses, like HIV, require the transfer of bodily fluids. Skin-to-skin pathogens, however, like herpes simplex virus and human papillomavirus, operate entirely on surface contact. This clinical map illustrates the limitations of standard barriers. Prophylactics leave the shaft base, perineum, and vulva exposed, shown in orange. Here, HSV1 and HSV2 transmit through asymptomatic shedding. The virus is highly contagious despite the total absence of visible sores. During the friction of physical contact, the virus sheds directly from these seemingly healthy skin cells and transfers to the partner's epidermal layer. This surface-level vulnerability has compounding effects. World Health Organization data shows that acquiring an HSV2 infection severely increases the risk of acquiring additional systemic infections, including a 3-fold increase in the risk of HIV. Prophylactic barriers statistically neutralize fluid-borne risks, but they are mechanically incapable of neutralizing surface-level viral shedding outside their limited physical footprint. The fourth misconception focuses on statistical probability, specifically the belief that coitus interruptus, or the withdrawal method, is a clinically reliable standalone contraceptive. This chart shows the stark delta between theoretical protocol and human execution. Across a 1-year timeline, perfect use yields a 4% failure rate. Typical use, however, results in a massive 22%. This enormous statistical gap is driven by a specific biomechanical variable, uncontrollable glandular secretions, combined with inevitable delays in human reaction time. This diagram isolates the bulbourethral gland, It involuntarily secretes lubricating fluid well prior to the main biological event. As this pre-ejaculate fluid sweeps through the tract, it can transport viable spermatozoa remaining in the urethra from a previous ejaculation. While small clinical studies debate the exact baseline sperm content of pre-ejaculate fluid itself, the 22% typical use failure rate remains an undeniable clinical endpoint. Relying on behavioral precision in a system subject to involuntary glandular secretions creates an unacceptable margin of statistical failure. The final misconception bridges biology and behavior, the societal view that consent is a static, one-time starting condition that acts as a binary gateway. Clinical psychology and behavioral frameworks reject this linear model. Instead, they model consent as an active, ongoing metric that must be maintained throughout an interaction. The internationally recognized Fry's framework sets the benchmark for establishing this metric. It dictates that consent must be freely given, reversible, informed, enthusiastic, and specific. The reversible metric is critical. It defines the mechanical capacity to halt the behavioral sequence at any point, instantly superseding any prior agreement. The specific metric recognizes that distinct physical acts carry distinct virological and biomechanical risks. Agreeing to one parameter does not grant permission to alter the variables. Together, these metrics transform the model of consent. It is not a straight line from start to finish, but a continuous feedback loop requiring constant verification. Biological safety protocols and clinical boundaries require this dynamic, affirmative feedback to function properly. Without it, the system fails psychologically long before it fails physically. Human biology operates on complex empirical data. Cultural intuition introduces severe clinical risk. We have mapped the friction physics of layered barriers, the morphological variance of mucosal tissue, asymptomatic shedding mechanics, the statistical realities of human error, and the continuous loop of psychological consent. In every instance, morphological variance and systemic unpredictability are the rules of human anatomy, not exceptions. Understanding these systems requires setting aside assumptions in favor of objective, peer-reviewed clinical education. Which anatomical system, statistical reality, or clinical assumption should we deconstruct in our next module? Let us know your parameters in the comments below.